And so with that, we're going to have a conversation today, everybody, and we're looking forward to meeting and really getting to know a little bit more about each of you and the roles that you play and the relevance of this conversation to the work that you're doing on behalf of the state. The conversation that we're going to have, going upstream and digging deeper, is as it implies. We're going to have a two-part conversation. The first part of our conversation is really about what are the ideas, the thoughts, the needs, the issues, some of the tools, the tactics of prevention, providers, preventionists, coalitions that are focused on prevention as they are addressing the deep concerns that are facing your state and across the nation. And then we're going to be able to provide a opportunity for us to engage in that conversation by digging deeper into that content and really thinking about pragmatic and practical application of the tools and the conversations that we will be having. You've already heard his voice. My great friend Dave Claussen will be kind of behind the scenes, and he is going to be helping to make sure that we have the best experience possible in this virtual environment. And in order to do so, even though we have all been on Zoom for more than a year now, I found that it's helpful just to have a little bit of an opportunity to make sure that everybody understands the various functions that we will be utilizing throughout. And so with that, Dave, if you wouldn't mind, just a quick tour around to make sure that we're all able to participate well.
All right, hold on. Get ready for a 60-second Zoom tour. Bottom left corner of your screen, you can see the mute and unmute button. I see you've already found that. We're going to be using that throughout today because we'd love to hear your voices. This is a conversation. Next to that would be the video on/off button. We would love to see your smiling faces if you're able, willing, and comfortable to have your camera on as well. Moving across the bottom of your screen, you have cues and participants and the chat button and reactions. Those are all different ways you can engage with us. When you click that chat box, it will pop up in the bottom right-hand corner of the screen. That's where I'll be hanging out. We do have some activities and engagement where we will be asking for you to use that chat box. Then also, if you look to the top right corner of the screen, it says speaker view. That is where you can switch between speaker view and gallery view. Changes the layout of the webcams and also the slide configuration on the screen. Play around with that and use whichever setting you like best. Lastly, the top of your screen in the middle where it says you are viewing Carlton Hall screen view options. When you click that little arrow, it gives you a drop-down menu. On that menu is the annotate feature. And when you click that annotate feature, a whole nother menu will pop up, and we'll be using the stamp feature, which is the fourth one in from the left. Now we'll be using that a little bit later on today, and then we'll give you a quick little refresher on that when we get to it. But be ready to engage in the chat box with your voice and annotate. All right, back to you, Carlton.
Thanks a lot, Dave. Appreciate it. It is my great privilege to have a remarkable group working with us today to be able to provide this training to you all. I want to make sure that we're going to have a little bit of time with each other today to be able to have this conversation. So I want to take just a moment out to allow each of the members of our team to do a quick intro of themselves. It is my great privilege to work with these folks. And so I'm going to start off, you've already heard his voice. Dave, if you wouldn't mind, just a quick soundbite about yourself and your background.
Yes, Dave Claussen, made my way to prevention as a campus police officer, discovered this whole thing called upstream prevention and prevention science and said, let's do more of that. Led me to the Illinois Higher Education Center as the assistant director, then to SAMHSA's CAPT, or the Center for the Application of Prevention Technologies. Now I wear a couple hats as the co-director of the Mid-America Prevention Technology Transfer Center, which is funded by SAMHSA to provide substance misuse prevention training and technical assistance to Missouri, Iowa, Nebraska, and Kansas. But then I also have my own company as well, DJC Solutions. And I am complete.
Thanks, Dave. And I am grateful to have co-lead training the first portion of our conversation today. Stephanie Struttner. Stephanie is also the owner and the operator of a consulting firm, Catalyst Evaluation Group, and Extraordinary Partners. Stephanie, if you wouldn't mind, just a couple of words.
Thanks, Carlton, and hello, everybody. Glad to make your acquaintance today. I'm Stephanie Struttner, and I am an epidemiologist, which before the pandemic, I had to explain to a lot of people what that is, and now I feel like I don't have to define that anymore, but I'm deep in data analysis and data evaluation, work with agencies across the country to help them collect data and have solid outcome measures and objectives to track their change over time. My background is in public health with a focus on biostatistics and epidemiology. And so I love using data to make decisions and to help people tell the impact of their story. Along with that, I have been heavily involved in public policy as it relates to health. And so I look forward to speaking with you today and appreciate this opportunity, Carlton. Thank you.
No problem. And I'm really, really gratified to be able to have with us one of my deepest partners, Hugh Life, and some extraordinary friends at Hugh Life who will be helping us to go into that deeper conversation. They are master trainers, and I would like for each of them to have the opportunity to share just a little bit about themselves. You're going to be learning more about them and having a conversation with them later, but I wanted to provide an opportunity for them to introduce themselves. And so I'll start off with you, Angie, and we'll go from you to Jeremy.
Ladies first, I guess it is. Okay, everyone, I'm Angie with Hugh Life. And for all you that are wondering what Hugh stands for, it's Human Understanding and Engagement. And so our company is based out of Minneapolis, but we're a multi-state organization. And I come to you from the world of coalition work. I spent over 20 years doing my own local stuff in my 15,000 population coalition. Eventually, we started a coalition in the state of Iowa, where I was a lead of our statewide organization called the Alliance of Coalitions for Change. Uniquely, we received a drug-free community support grant for the whole entire state. Got that going, and we got funded for 6 through 10 here a couple of years ago, and I left them in good hands, and I came to Hugh Life full time because engagement is the how to all these wonderful theories and things. And so I'm so excited to be able to share it with all of you and everyone else across the country. But my colleague, Mr. Jeremy, has a lot in common with Miss Stephanie.
I guess that's my cue. Thank you, Angie. So pleased to be with all of you here this morning. My name is Jeremy Kautza. I normally come to you from Madison, Wisconsin, where I also work for the university as an internal consultant. My role at Hugh Life is an exciting and a fun one to be working with this team and to work with folks like Carlton and Stephanie and Dave. But I'm a facilitator, consultant, and trainer, and responsible for a lot of the curriculum that we put out in presentations that we have. Being from the world of education, I've been a lifelong facilitator of learning, I like to say, starting off as a high school mathematics teacher, doing that for, I don't know, 15, 16 years, and then really getting into the world of facilitation, consulting, and training after that. So really excited to be here with you today and to take you on this journey, which Carlton is going to kick off for us right now.
Thanks so much for the kickback, Jeremy. Appreciate it. Everybody at CHC, I've been and we've been in this work for more than 25 plus years, and I've had the extraordinary privilege of working with your state for a good number of years. And so I am honored and thrilled to have this opportunity to be able to bring this team together, to be able to help us kind of have a conversation that is really important and in the context of the times that we are in, and to help us think more rigorously and critically about how we're applying prevention and prevention science on behalf of the work that you all are doing in the state. So I am gratified to have this team with me, and I'm also very, very grateful for the leadership and the opportunity that was provided to us by DSAM. And with that, I'm appreciative of the leadership offered by Joni Patterson. Joni, thank you so much for all that you've done to help make this happen. And if you wouldn't mind, could you provide a few words of welcome and opening for our efforts, and then we'll get started with the training.
Sure. Thank you, Carlton. Good day, everyone. My name is Joni Patterson. I'm a planner with the state of Delaware, and I'd like to thank you all for attending today's meeting. And the Delaware Division of Substance Abuse and Mental Health is happy to partner with Carlton Hall Consulting and his Avengers to bring this opportunity, which has been made possible by SAMHSA's Strategic Prevention Framework for Prescription Drugs Grant. We're excited to learn and grow with you all as we go upstream and dig deeper into the critical role coalitions play in addressing the nation's opioid and heroin crisis. So thank you so much for coming to today's meeting, and I'm excited to get started.
Terrific, terrific. Thank you so much, Joni. Just as a way of starting us off, it's just a little bit of a disclaimer. As you might know, some of the funds are being offered through the Substance Abuse and Mental Health Services Administration. And so as such, I'm obligated to share with you that the views that we're expressing and all that we're doing today does not necessarily represent the views, policies, and positions of SAMHSA, and therefore they are now off the hook. And we can have our conversation. This is all about how do we build our capacity with this. And as I mentioned, the first portion of this conversation, we're going to have with my esteemed partner, Stephanie Struttner. The objectives of today, so that you understand kind of where we're going to talk a little bit about that epidemiological triad and look at the ways in which that relates to the work that you will be doing in kind of applying the strategic prevention framework to this. We're going to have a conversation about the factors that lead to the kinds of behaviors that we are attempting to address, and how coalitions can align effectively towards addressing strategies that meet the needs of their local conditions. We will have some opportunity to look at specific examples of how all of this works. And then Angie and Jeremy will come on after we take a little bit of a break. Don't worry, we're not going to have you in front of your screen for the entire time. We're going to provide some real interactive time, but we're going to give you guys a little bit of a break in the middle of this before Jeremy and Angie takes you into a much more deeper conversation, facilitated conversation that we're going to have. I want to start off this conversation by just kind of setting the stage and sharing with you guys that something that I'm pretty sure that many of you are really familiar with, right? The notion that this crisis that our nation has been addressing for quite some time has often been talked about in terms of three waves, right? The rise of prescription misuse that kind of led the path and created the context for folks to fall into addiction patterns around opioid misuse. And then that given way to a second rise or second wave in the rise of heroin that took place somewhere around 2010. And then a few years later, we started to see this really steep incline and transition to synthetic opioids, including fentanyl, which has devastated communities that we are all familiar with. The latest data shows that that pattern has continued, but as we are looking deeper into that pattern, we are noticing as well that psychostimulants such as cocaine and meth have been on the upsurge as well. And so needs to be a part of the consideration, because if you actually look at the numbers that are taking place nationally, that rise in rise in psychostimulants is actually equal to the synthetic opioid issues that we are that are ravaging our nation today. And so there is a consideration that we have to go beyond thinking merely about any single substance, but rather that this is a polysubstance misuse issue that we need to prepare our communities to think more critically around and about. And so I refer to that as the fourth wave that is going on with respect to what's happening in our country. And all of this is happening within the context of what it is that we have been dealing with in our nation and actually globally. And in fact, it is now documented that the pandemic has indeed exacerbated a lot of the issues and the challenges. In fact, we now have data that shows within those first months of the pandemic that overdose increased up to 40% per month during those first months of the pandemic when compared to the same time frames just a year before. And that increase has been showing up, but showing up kind of differently in different communities in different states. And I bring this up only to share that in the context of the information that Stephanie will be taking us through, there's been a very acute issue in your state, a state that I care passionately about. And as we are looking at this, it's more than just the numbers, it's what these numbers actually represent and how we can reframe what it is that we're doing and how we're thinking about this. And so the remainder of this conversation is really about what Dr. King referred to as this fierce urgency of now that I've been sharing around the country, and my colleagues, my partners, I've also been trying to raise the alarm about how we need to begin to have different conversations and make sure that we're raising the level of our game. And so the remainder of the time that we're having together is all about how do we raise the level of our state of play? How do we raise the level of our game with respect to this? And so I'm going to invite my colleague, Stephanie, to come up now and to begin to share and go deeper into the kind of tools that will be important for us to understand if we're going to have that conversation. There's going to be a lot of interactivity that we're going to have throughout. Don't worry, this is not a didactic presentation, but I wanted to set us up well. And so with that, Stephanie, thank you so much and take us forward.
Thank you, Carlton. And all right, everybody, put on your seatbelts because we're about to move fast. And Carlton referenced how do we dig deeper? How do we figure out how to move forward and move upstream to address some of these polysubstance use issues that we have in our community? And so the first thing that we want to do is to understand the epidemiologic triad and its connection to prevention. So if any of you have ever had any training on the public health approach, you're probably familiar with this. It's this concept where we have an agent and a host and the environment, and they work with and against each other that move people toward behaviors in our specific conversation today, leading towards substance use. So let's translate that to layman's terms. We're just talking about a drug, a person at risk to engage in drug use behavior, and the community in which they exist. And then these are all connected by potential substance use. And so if we use this as our platform for moving forward, gives us the opportunity to engage in this just mental image of our community. And so if you think about this river as the community in which we are all working, you see some things that are happening. What do you see happening that is a little bit out of character in this picture?
You want them to put it in chat?
You can unmute or put it in the chat. I know Dave tested everybody's microphones, so they're working. So let's have a conversation. What do you see that's going on here? Well, I can start us off by saying there are some people floating in the river, and there are some additional people who seem to be jumping in to help. Do you notice anything else in this picture? Yeah, Joni says everybody's looking around and wanting to jump in to help. What else?
It looks like they're going towards a waterfall.
Yes, there's a waterfall, thank you, at the bottom, and we see some rocks, and so there seems to be an imminent need to address the situation of these people moving down the river. Do you notice anything else about the picture? So we have, if we think about the epidemiologic triad, we have these hosts. They're the ones who are floating down the river. We also have some helpers. But there's also this one thing that's a little bit unusual, because there's this one person who seems to be running away from the problem. And so what in the world is he doing? Well, this guy represents the coalition, if you will, or the agency in the community that's looking to go upstream, if you will, to initiate change. Because what's happening is, while he's running away from the problem, what he's doing is going upstream to identify that there's an agent upriver who's pushing a person who is our host into the environment, into the river, and downstream there are some consequences associated with that happening. And so this whole collective space here is the environment in which we are working, in which we live and play. And so as we think about the epidemiologic triad, the person running away is the coalition, because what we're doing is moving upstream to prevent the behavior from happening in the first place. If we can prevent the agent from pushing the host into the river, we can prevent those negative consequences on down the way, and we don't have to have all the helpers in place. And so what this concept shows us is just our ability as communities and as coalitions to go upstream, to think about the problems and address the problems from the root cause, so that we don't encounter the consequences on down the river. So in order for us to have a really strong grasp of when we think about strategies on down the line, we have to introduce this concept of the strategic prevention framework. And so the strategic prevention framework is a product of Substance Abuse and Mental Health Services Administration, and it's a 5-step process with 2 guiding principles that gives us an opportunity to have a approach to address substance use and the related behavioral health problems facing our communities. With the strategic prevention framework, it's not necessarily a step-by-step pattern. Rather, there are multiple steps that we continue to cycle through over and over again. So it's not a once and done process. Rather, it's something that we are continually engaged in to make sure that we as community leaders continue to have our finger on the pulse of the behaviors and the conditions that are existing in our communities. And so the purpose of the strategic prevention framework first is to be dynamic and interactive. Second, we want it to be data driven. So we want to make sure that we have the information from the community that backs up the perceptions that people hold. Third, it's an evidence-based process. And so if we work our way through each of these components, we're working through an evidence-based process. It's also reliant on and very encouraging of this team approach in the community. And what makes the strategic prevention framework really work is when we are inclusive in our planning and make sure that we have people from all different parts of the community in the planning process. We want the planning process to look like the target population, and in so doing, we work toward that cultural competence piece and also sustainability. The cool thing about the strategic prevention framework is it's applicable to any issue or any problem in our community. And so it gives us that brainstorming process to work through to identify some of the needs and resources in the community that then give us the opportunity to build targeted capacity around some of those areas, and then engage in some planning with the people in our community. One thing that's really important when we think about planning is this concept of nothing about me without me. We want to make sure that we are inclusive in that planning approach, including both the experts, the subject matter experts in the community, but also members of the population that we're trying to target. And then finally, once we are inclusive of all of these different stakeholders in the community in our planning process, we get to the place of implementation. And you and I both know that we can't possibly do everything it takes individually by ourselves to change the behavior of everybody in our entire community. But if we are inclusive and engaging during this process, then we have all of these players in the community who are there at the ready to help us implement all that work. And when we do, we're able to have a much larger reach. So then we get around to this spot of evaluation where we want to continuously evaluate our work. One, to make sure that we're efficient in what we're doing. And second, to make sure that what we're doing is meeting our intended objectives, to make sure that we're doing what we intend to be doing. All the while, we want to continue to think about how we're going to sustain these efforts for the long haul, engaging community partners, and also being culturally relevant through the process. So again, the elements of the strategic prevention framework align us in a position to assess the needs, then build capacity around them, plan, then use our target population who have been engaged in that process to implement the work, evaluate it, and obviously sustain it for the long haul for population level change, and continue to be aware of, knowledgeable about, and inclusive of all of the cultures that exist within our communities. So we should have opportunity for a breakout room here. And I want you to consider this point of discussion. One, and Carlton, I'm seeing your eyes getting big. We're not doing a breakout here? Okay. Your mission is to get your kids safely to school or get them on the school bus by 7:42 when the bus stops at your stop using the strategic prevention framework. And so we don't have to necessarily go into a breakout room right here. We can do this as an individual activity. And so you have 3 minutes to write down your plan of how you're going to get the kids in your care on the school bus by 7:42 using the strategic prevention framework. All right, your time begins now.
Stephanie, we can do breakouts if you wanted to.
Okay, are we good to do breakout, Dave?
Yeah, I've got 2 rooms set up right now, but I can rearrange them. What would
No.
you like?
2 rooms is great. I was looking at Carlton's nonverbals and was afraid.
No, I'm sorry. I was interacting and dealing with things that
Okay.
had nothing to do with you.
Cool. All right. Yeah, let's do breakout. So in your breakout room, collaborate with your group and have somebody be the reporter to report back to us on what your plan will be using the strategic prevention framework to get your kids in your care safely on the school bus by 7:42.
3 minutes? How
3
long? 3 minutes. All right. Good luck.
Great way to get them talking, so.
Yeah.
Good deal.
Sometimes folks are a little slow. Their
Yeah,
computer's a little slow.
I was in the midst of typing out a message to you. My eyes had nothing to do with your comment.
I
Seems
saw
like
your eyes get about this big, and I was like, "Oh, we're not doing the breakout." Okay.
There seems to be a number of folks that are indicating that they have a good deal of experience with the SPF. Okay.
Okay.
So just as a note.
Got it. I saw a lot of chatter in the chat box, but I couldn't keep up with it all. So
It's all good.
I'm trying to get them talking in class.
Yeah,
I like that.
that's what we're trying to do.
So I'm going to go through this next section pretty quickly then.
Yeah.
And focus on the opioid aspect of it.
Yeah.
I was just going to leave them in the 2 breakout rooms with 5 each for the next. Okay. Cool.
Because they'll be more comfortable with each other and in their conversations, getting to know each other in this breakout.
All right. Let me see if I remember that trick you showed me, Angie. Where is it?
Join.
I don't
Click on
see
your
it.
breakout rooms and then they pop up and then you hit
There you go. There you go. Here we go. All right. Bye.
go join them.
Does somebody else want to take over planning, or, I mean, I can keep on going. I just feel like that's not a group activity.
Hi, this is Marlene. I apologize. I had a situation that I had to deal with. I'm at a Boys and Girls Club.
Oh,
I'm so sorry.
That's all right. Don't worry about it.
you're good.
Anybody else? right, so I'll keep on going then, that's fine. So planning, it would be determining what time, planning for what time the children need to wake up, how much time they will need to get out of bed, how much time they will need to put their clothes on and brush their teeth, eat their breakfast, making sure that all their clothes are either laid out, their backpacks are packed, lunches are packed, or when they need to get packed, and all of the different aspects, and plan them out. Implementation would be really the process of doing it, following that plan and making sure that everything that is planned out is actually happening. And then evaluation once the kids are on the bus, making sure that we review how did that go? Were we rushing too much? Did we allocate enough time on every element of the process, or do we need to add time, shift time to somewhere else, wake up earlier, make different arrangements for.
And here they are.
So getting the kids in your care on a bus, solving complex community issues, planning a trip, so many ways that we can utilize this strategic prevention framework. So we want to hear from you all, the reporter from your group. Tell us how you worked your way through the strategic prevention framework to get the kids on the school bus by 7:42. Let's start with group number 1. So that would be Claire's group, Cheryl, Brandy.
Okay, I'll start to report. This is Cheryl, and the other group members might jump in and help me out. We just kind of went through the whole process, and I hope we did it the correct way. We were looking at getting our own children on the school bus. So as far as assessment, we kind of decided we needed to take a look at the data we know about our children. How many times we have to wake one of them up? What do they want for breakfast? That sort of thing. So we're just kind of take a look at our individual children's characteristics and what we would need to have available. For capacity, we took a look at, well, do I have those things available? Am I able to do that? Do I need to have some reinforcement? Do I need to make threats to these children? And then for planning, we were going to look ahead and make sure that they had their clothes ready for the next day, that we knew what they wanted for breakfast. So we had that all planned out. Then we're going to do what we need to do, get them dressed, get them breakfast, stand at the door, wait for the bus. So that was implementation. And then evaluation was, did they make it on the bus on time safely? Did they have to run? Was it calm and organized? Just kind of took a look at the way we handled it and how it worked out. So if anybody else wants to jump in from the group, feel free.
We definitely wanted to make sure that we included the children in that process. So the morning of trying to get to the bus, those are not the socks that I wanted to wear. Hold them accountable. That's not what I wanted to eat. Hold them accountable. So really including them in that process.
You all were not joking. You are experts in the strategic prevention framework. Job well done. And I'm taking notes to find new and innovative ways to get my 4-year-old out the door in the morning. So thank you for that. Group number 2, did you all come about this process in a similar or different way?
I'm not sure. Were there just 2 groups there?
There were, yeah. So Kate, that would be your group, and Carolyn and Andrew, Marlene.
Yeah, we pretty much followed the same logic. I have to admit, we did not include the children, and that might be just kind of the part of my children are a little younger. They are 2-year-olds, so they don't quite participate in the planning aspect of these things yet. But that was an excellent point to make.
Thank you for that feedback, Kate. Anybody else from group 2? I have, to follow up on your comments, Kate, learned that lesson, that valuable lesson in including the target population in the planning, because if I pick out an outfit that my kiddo does not want to wear to school the next day, it takes twice as long to get ready to get to school. And so a very home run opportunity for us to remember about engaging our participants in our planning. And so the whole point in this activity is we don't have to be experts in this theoretical strategic prevention framework process. We are already experts in a planning process. We do it every day. And so when we translate this idea to people in our community, we don't have to use complex language. We can use the language that the people with whom we're working understand. And so I encourage you to use that language in a way that is easy to understand for the people that you're working with. And so we'll work through the strategic prevention framework. However, I recognize your expertise in the subject. And so I want to focus our attention specifically on what do we do each of these phases specifically related to opioid use. And so a lot of us have existing community assessments where we've looked into underage drinking and nicotine use and marijuana and sometimes other substances. However, if we're looking at opioids maybe for the first time, we want to go through that community assessment again and think specifically about how we measure opioid use and the consequences of non-medical use in our communities. And we want to be able to prioritize those problems with respect to the magnitude, the time trend, the severity, and in comparison maybe to another subpopulation. And so as we're doing this, it might be that in your target population, prescription opioids are going to be the number one priority. It might be that it's already gone and transitioned to heroin. And so we will figure this out by engaging in that community assessment. As Carlton mentioned, the pandemic has exacerbated some of our substance use issues that we face in our communities, especially as it relates to opioids. And as we move on that continuum of opioid misuse, where oftentimes we start with prescription opioid pills that moves into different routes, eventually ending up with heroin. And so with this idea that the pandemic has brought on excessive use, because people are often self-medicating for some underlying mental health conditions, the stress, the anxiety, the financial strain that comes with a pandemic, we have what we call now a syndemic. And so this syndemic is where we are incorporating the opioid epidemic with the COVID-19 pandemic, and they're working really in concert with one another to exacerbate this problem. And so we want to be able to assess the risk and protective factors specifically as they relate to opioid use. And we can even tie that into the COVID-19 pandemic and how the nature of the pandemic has changed the landscape of our community and how we can use that moving forward, both identifying the threats that it poses, but also identifying the opportunities that we can use as we move forward. And as we do that, thinking specifically about opioids, when it gets to capacity, there are a few areas where we really want to make sure that we have the right stakeholders engaged in the process so that we can really strengthen our prevention team. We're talking now about medical examiners. Your medical examiner is going to have a wealth of data related to fatal overdoses and what drugs were detected in that overdose victim's blood. Oftentimes, as Carlton mentioned before, we're seeing substance use being a contributing factor here. But also we want to collaborate with doctors, with dentists, with veterinarians, also with mid-level prescribers who can often be overlooked, but they're also prescribing opioids, especially in more rural areas. We also want to collaborate with insurance providers. Insurance providers are the bridge between where we are and where we want to go to really reduce our reliance on opioids to treat pain and open up the opportunities for non-opioid choices for effective pain treatment. And don't overlook the businesses in your community, because businesses are a conduit to the people in the community who are the healthcare consumers. We want to make sure that we're reaching them as well so that we are building that large-scale community awareness about the problem. And then, of course, we want to make data-driven decisions. And it's really easy to go out in the community and do what is expected of us and do what feels good. But we want to engage in the strategies that are effective at contributing to change. And in order for us to do that, we've got to be reliant on the data and follow where the data is leading us. And that gives us an idea of where we need to start with respect to planning and doing our work. And so, for example, we want to not only prioritize our risk and protective factors, but we want to assess community readiness. Where are people in the community with respect to their adaptability and their idea on community readiness related to, specifically today we're talking about opioids, to identify where we start with our interventions. Because it's one thing for your organization to know where your organization is with respect to readiness. But if we're trying to achieve population level change in the community, we have to meet the community where the community is, not expect them to fast forward to where we are as an agency. And so when we're selecting interventions, we want to make sure that we're selecting interventions that are effective at moving people from their readiness level to the next level of readiness. A great tool to use for assessing community readiness is the Tri-Ethnic Community Readiness Survey. It's a product of Colorado State University, and it's a packaged toolkit that you can use to identify strategies to move first to assess where the community is, and then identify strategies to move the community across that continuum of readiness to where there's widespread ownership. That gives us the opportunity to establish our logic model, which gives us that roadmap or our plan for how we implement strategies to address change. When we get to implementation, we want to make sure, because again, this is a widespread issue, and so we want to collaborate with those community partners who can institutionalize the implementation of these strategies, because your goal as a coalition is to keep your finger on the pulse of what's going on, correct? In order to do that, we have to pass on these new approaches to the most appropriate entity in the community who can continue to implement those strategies for the long haul while the coalition continues to address new and emerging trends. And so in order to implement effectively, we have to make sure that we are establishing those supports and implementing with community partners so that our work is sustainable. Finally, when it comes to evaluation, we want to measure the opioid use and the consequences of non-medical use with the data that we have accessible in our community, but we want to make certain that those data are mapped to our problems, our root causes, and our local conditions. If we evaluate in this way, we're going to be much better positioned to articulate the impact that the community's efforts have had on addressing the problems that we've outlined. And when we do that, it gives us credibility, it gives us the opportunity to increase engagement and really expand our network. And so while, I mentioned earlier about working with insurance companies, sometimes for agencies thinking about working with an insurance company might feel out of reach. Well, maybe it is for a brand new entity that's working on prevention, but once you start showing the change that you're achieving in the community, then you're able to build that credibility and you're able to expand your work to larger, sometimes more corporate organizations. And we've talked about sustainability already and identifying those community partners who can support our strategies for the long haul. And so in thinking about going back to our school bus planning activity, we want to make certain that we're including those partners from the very beginning. And sometimes those partners might not be the first people we think of when we think about who are we going to invite to our planning process. But if we get them at the table in the beginning and we can hook them, we get that engagement from them in the very beginning, then we have a much better infrastructure built so that we can support that over the long haul. And then when it comes to opioids, we really have to consider cultural competence here. It can be really easy for us to stigmatize the use of opioids while we're trying to prevent the misuse of opioids. And so especially when we're talking about treating pain, we want to be very clear and respectful in the language that we use and the way that we talk about opioids and the way that we talk about non-medical use. And so using person-first language is really critical here. Being careful not to stigmatize the proper use of opioids, and also being careful not to try to make people feel like we just want people to experience pain, because we don't. We just recognize as preventionists that there are different pain pathways and there are different types of effective pain treatment for those different pain pathways. And so thinking about cultural competence, we want to keep in the back of our mind always this idea of stigma and how can we continuously reduce and prevent stigma associated with use, while and also a person who might be an active user or a person in recovery, but also preventing the initiation of use for people who have not used the drug before. So another point of discussion, and we're going to go back to the same breakout room that you had a conversation before. And the question here is, have you ever used the strategic prevention framework to address opioids before? So specifically opioids, and then have a little conversation about, was it helpful? What did you like about the process? And how could you use ideas that you hear from other people in your work? Any questions about what we're asking you to do?
And if I could just add one piece before, and as we go to our breakouts, folks, we recognize that there's a great range of experience that is joining us today, which is fabulous. We can all listen and learn with and from each other. Feel free, please participate with the breakout conversations and breakout discussions, and bring up things that are at your level, right? And we're able to engage with you where you are around all this. Looking forward to the conversation when we go into it. Thanks so much. All right, Kate, you took the lead last time. Who else is going to take the lead?
Thank you. I appreciate that, Carlton.
Danielle, are you here?
I'm here.
Hey.
Just getting a lot thrown at me on a Friday.
I hear you. It is a Friday.
It's tough. It's been very busy with the Boys and Girls Club the past weeks. Just starting yesterday, we're opening up for volunteers again. So,
Got it.
It's intense.
Got it. Grateful that you're here. Andrew, are you here?
Yes, I'm here.
How are you?
Doing good, doing good.
Good deal. So Andrew, what organization are you with, if I can ask?
I am with West Virginia Prevention Solutions, and I'm the Coalition Engagement Specialist.
Oh, perfect.
And my work is specifically tailored to opioids. So we use, the strategic prevention framework all the time, constantly.
Got you. Well, welcome. Thank you so much for joining us with this. Appreciate it. Hey, Carolyn, how about yourself?
I'm here and I work with Andrew at West Virginia Prevention Solutions, and I'm the Adult Intervention Specialist, and I work under the SOAR grant, which is opioid related.
Yeah.
And my focus is adult suicide prevention.
Got it. So what aspects of the SPF present the most challenges?
I'd love to know.
That's the thing that I would ask. So I'm gonna go with Danielle. Danielle, you said something, so I'll go with you first, and then I'll come to Andrew and
Kat. Oh, well, I'm here today to learn and listen more than anything else. I'm working towards my prevention specialist, but I oversee these different prevention grants and all different other project management and development and program management and development. But I am learning, but to hear Andrew and Caroline's and Kate's background, I'm like, looking up to all three of you to hear your thoughts, because that's how I'm developing. So I'd love to hear your other thoughts, but we're actually looking to take on another very large grant in suicide prevention and youth violence. Beautiful. And I'm working on the grant proposal currently. So I'd love to hear some ideas.
Beautiful. Thank you for sharing it. And I know your organization really well. It does extraordinary work throughout the state. So thank you for
yeah, we're doing great. Just very, very busy. And it's suddenly just really picked up with the changes in the state and the regulations with the pandemic and stuff. So we're really moving quick here.
So for the purposes of this conversation, Andrew, I'm gonna come to you first. What challenges, as you've been helping communities and folks kind of apply the SPF, particularly as it relates to opioids, what challenges have you found?
I would say it's because every community you work in they are very different.
Absolutely.
While you're trying to work toward the same goal, everyone is in a different place. So you've got to meet each one individually where they are. So it's not a one size fit all.
Without question, without question. Carolyn, you've seen much of the same, I'm sure. Anything to add to that?
No, I agree with Andrew because, like he said, each county that we represent is at a different place and time. Some still haven't grasped the concept of what's going on, so they're still at an assessment stage. Some of them are gung-ho and ready to go, so then they're at the implementation stage. So you just have to take it step by step by step, and it just depends on each one. And that's the hardest, to get everything together, even though we're all working towards the same thing.
Without question. Kate, what organization, can I ask, are you with, and what role do you play?
I'm with the Division of Public Health here in Delaware, and we do a lot of prevention and education work when it comes to opioid epidemic. Our office in particular at DPH is the office that helps coordinate on behalf of our whole division, all the work that is being done on behalf of the opioid epidemic here in the state. So we also partner with a lot of state and other agencies. So we work with DSAMH, we work with DMMA, we work with Department of Education, Department of Kids, and we try to partner on what their activities are so we can align efforts. We also, in our office, manage the Help Is Here DE website that has the repository of all information in Delaware on the opioid epidemic services and prevention aspects. We heavily focus, since we are a public health agency, we've heavily focused on prescriber education and modification of prescribing practices, safe opioid prescribing and non-opioid treatment alternatives. But a lot of community work as well. We have, in particular, a rural communities work group that we are looking at specifically for Sussex County, rural Sussex County, and how we can assist with some of those hard to reach areas and what needs are. So we have done a needs assessment. We have created coalitions to help us come up with solutions to the rural community problem when it comes to the opioid epidemic. So lots and lots and lots of work. We have several grants here in our office that we're managing, and with that comes a lot of work that we do.
I would imagine, thank you very much for sharing and offering that. I would imagine that a lot of what it is that your folks might be finding, particularly in the realm of Sussex, is probably very similar to what Andrew and what Carolyn might be working with as well in engagement, but probably some commonalities there. I mean, West Virginia and Delaware are very similar, are very different, but there are aspects of both of those states that have huge commonalities, and I've worked in both. Andrew and Carolyn, are you familiar with a friend of mine, Greg Puckett?
Yes, we know Greg Puckett.
Tell Greg I said, what's up?
Absolutely.
All right, it's great to have you. Can I ask? Andrew, would you mind when we go back to the big room to kind of report out for the group?
Yeah, I could do that.
Yeah, just summarize, and that'd be fantastic. And throughout this thing, folks, we have varied experiences here. Danielle, thank you so much for sharing your participation and your level and what it is that you're hoping for out of this. Everyone, we have varied experiences here. Please share at your level and bring that to the conversation so that we can go as deep as we need to go with these conversations. So thank you so much.
I mean, the Boys and Girls Club, I just was talking with our executive leadership today. We're looking to form a coalition in Dover within the next year or two. But we are looking to build that capacity and to start small this year, but particularly in year 2 or 3 of this SABG. So
there's going to be much of what it is that you're going to get out of this training today. And later on, the second portion of the training, where we're going to actually have a lot of time to fully engage in full conversations, there's going to be a lot that you'll be able to take back. And Andrew and Carolyn, I'm really happy that the invitation was extended out to you guys. Are you guys located actually in the state in West Virginia? Are you there?
Yes.
Wow, man, I appreciate that. It's been a minute since I've been out there. We should have some convo. But bring your stuff to this conversation as well. I really appreciate it. So I am, any other or additional thoughts before they beam us back into the room? I feel like we have Star Trek and we're on a countdown before before we get beamed back out. If not, then it is play. Kate, what role do you actually play with DPH?
I'm the director of the Office of Health Crisis Response.
Thank you so much for being here, and thank you for bringing your expertise to the conversations.
You're welcome.
All right, folks, I'm gonna see you on the other side.
Welcome back, group 1. Here comes group 2. All right.
Hi.
Welcome back, Crystal.
Welcome.
The whole group should be back soon.
Yep, everybody should be back. We are ready. Oh, there they are. Popping in now. All right.
Excellent. So we heard from group 1 first last time. So let's switch things up a little bit and hear from group 2 first this time. Of the members of group 2, how many of you picked up something that you learned from another coalition? And if so, what was it?
Who would be in group 2?
Guys, but our group, it said that I was in session, like the room 2 this time, and I was in room 1 last time, but I wasn't with the same people as the first time.
Okay.
Oh, okay. So we switched it up. Well, Brandy, since you're talking, would you mind to tell us something that you heard that was innovative or cool that you want to use?
Sure. So all of us were from Delaware and West Virginia. And so one of the issues we really talked about was like transportation in both of our states. We have some of those issues. So looking at that SPF flower, jumping down to evaluation, it's really hard sometimes to get that evaluation. And I mentioned that I'm one who wants immediate gratification. And I understand that things take time, but I'm like, I want answers now. So sometimes I have to reel myself in to say that's not going to be effective. That's not the best way. And as we were jumping back in, Crystal had mentioned that the pandemic has really helped bring some more voices to the table for like capacity building with our youth. And I completely agree. Zoom has been a blessing and a curse. So looking at the positive, Zoom, we really have been able to reach our population a lot more. And specific to opioid awareness, we do toolkit training with all members of the state who's ever interested with agencies to help distribute the DTaRA bags for unused, unwanted, and expired medications. Relating that back to transportation, a lot of individuals can't make it because they don't have the transportation to a permanent collection site. Delaware has over 20 of them in all 3 counties. And I know that Eileen and Katie can talk more to that if they wanted to share where they were. Airbag is that great alternative to help dispose of unused medicine, so to help prevent opioid awareness. And there's a plug. Tomorrow is the DEA Take Back event. We are working hard to do that, so check the DEA website.
Yes.
Well, you beat me to it. You beat me to it, Brandy. Go ahead.
We are doing a big event tomorrow, so if anybody is, in the Middletown, Delaware area for whatever reason, come visit us at the police station. But with transportation, that was one of our biggest focuses. And I guess with youth, it's kind of hard because I know Cheryl was talking about it as well. That's not really a target substance with the youth that we see. So, I could just keep talking. So I'm going to stop. But if my group wants to say anything else, that's wonderful.
That's really helpful, Brandy. And one thing that I thought about when you were talking about your need for instant gratification. I would say me too, but I'll also say everyone else too, because we all need that reinforcement that what we're doing is working. And so that becomes our challenge with evaluation. How do we utilize our evaluation so that we get the instant gratification to show members the impact of their work? And if we have a comprehensive evaluation plan, which we'll talk about this in just a few slides, is if we are mapping the right data, then we will have more timely data to show people that what we're doing is making a difference when we're identifying the short term, the intermediate, and those long term objectives. So I'm glad you brought that up. What else did you all hear that was a great idea that you want to try to implement? Maybe from the other group?
Andrew, you got us?
So what we talked about is, like, personally, the organization that I work for, we cover 13 different counties. And every county is vastly different. I mean, they can be right next to each other, and where they are in the process is very different. And it can be even be the substance that they feel like is the biggest or most commonly used is completely different. So our challenge was, with, I guess it would be assessment, finding like what works for specific counties.
Yeah, understood, and really underscores that importance of including the target population in your planning. Right, thank you for that, Andrew. I'm going to go ahead and carry us along forward. Thank you all for engaging in that opportunity for networking and brainstorming. I really believe that we learn a lot by collaborating with others. And so I want to touch just briefly. I recognize that a lot of you are advanced in your prevention understanding, but I do want to touch on risk and protective factors just for a moment to acknowledge the basic concept of our moving forward, and that risk factors are associated with a higher likelihood of negative outcomes and can exist in different domains. And protective factors as well are associated in different domains, but associated with a lower likelihood of negative outcomes. And so ultimately, in our communities, we want to mitigate risk factors with more protective factors so that we outweigh the risk with those protective factors that exist in relationships in the community, within communities, neighborhoods, or communities within our community, and also in the general society. And so why is it that coalitions sometimes fail at meeting our objectives? Well, we all want to be perfect. I know we do, but sometimes we know the information up here. We just aren't able to clearly articulate it on paper or electronically. And so we might come up with ideas like there's no education on opioid use in school, but what we really want to get at is the behavior. So we're talking about local conditions here. And if we're talking about there not being a lack or there being no education on opioid use in school, where we really want to get is youth use opioids they steal from unlocked and unmonitored medicine cabinets at home after school before their parents get home from work because they're trying to cope with anxiety. We tie this into the pandemic, or we can tie it into their excessive schoolwork or whatever the things may be. Ultimately, we want to say our local conditions in the right way. And if we express it in terms of a behavior that is specific, that is identifiable, that is actionable, then we're able to map a set of strategies to those local conditions so that we can be effective at creating population level behavior change. We call this the why technique. And so we want to use this question driven approach to ask ourselves why. What does this problem look like where I live? And I believe it was Brandy who identified that there are transportation issues and that there are people that live in different parts of the community. Some are more urban and some are more rural. And so the substance use problems are likely to look a little bit different in those areas. So how do we use the question-driven approach to get specifically at the behaviors of each of these individual communities? We want to utilize, again, that broad group of stakeholders to help answer these questions. We want to know the when, the where, the who, and the circumstances around the behaviors that are occurring. And if we do, we then are able to identify those strategies that help us to move forward in identifying a comprehensive set of strategies that will lead toward change. And we do that by using a logic model, whereby we identify a problem as well as risk factors, or some of us call these root causes. And for every root cause, we identify multiple local conditions, or those behaviors that we see in the community that are specific to the community where we live and work. And then we map data. So the data we map for our local conditions are going to be our short-term objectives or our short-term outcomes. The data we map to our risk factors are going to be our intermediate data or intermediate outcomes. And then the data we map to our problem are going to be our long-term. This gives us that roadmap to where we can be very successful in moving change by mapping those strategies. So this is just an example of what a opioid logic model might look like, where we might have social availability and community norms, and social availability might look like students selling legally prescribed drugs to their peers at school. And so we want to make sure that we are clearly identifying those local conditions so we can map strategies. Risk factors can be inclusive of many different things, both favorable youth and parent attitudes, community norms, retailer social availability, laws and enforcement, and obviously price and promotion. And so when we dig deeper to understand the problem, we want to identify what are the consequences associated with these behaviors, what drugs are being used, how much of them, how often, and where are they coming from. And then when we think about our root causes or our local conditions, we want to know how people are getting the drugs that they're misusing, what laws and policies are impacting the use of those drugs, and what are the perceptions that people in our communities hold. So when we think about data related to opioid use, there are a number of places that we can start. As you're beginning to compile these data, I encourage you to look at opioid overdose deaths, non-fatal opioid overdoses, maybe hospitalized, not hospitalized, number of naloxone deployments, prescriptions per capita, availability of non-opioid pain treatment alternatives, or perception of harm of non-medical use of opioids, number of opioid use disorder treatment providers. They're in community readiness, of course, to address opioid misuse. A number of other places that we can start with data. So a good idea is to have a conversation in your community. And so this is where we're going to use the annotate feature. And so if you'll click on your Zoom toolbar, there is a pencil looking icon that says annotate, and you can select draw and select one of those tools. And what I'd like for you to do is circle all of the strategies that you see in this picture that might prevent someone from speeding. So for example, well, you all are certainly speedy. Job well done on being the fastest respondents to this exercise. You nailed it because you identified so many different options for how you could prevent, strategies to prevent people from speeding. Now, we might argue that none of these strategies would prevent Carlton Hall from speeding, but now some of these strategies would prevent Stephanie Struttner from speeding. Primarily the speed bumps, because I don't want to spill coffee on my white pants. But some of these strategies clearly are going to cause some of us to not speed, and some of us might overlook. So the importance here is to be comprehensive in how we ensure that combination of strategies to create change among everybody in our population. And so we have strategies at the individual level, like providing information, building skills, providing support. We also have strategies at the environmental level. And these are the strategies that identify change for the entire population, sometimes whether they want the change or not, like changing access or barriers, or changing consequences, or changing the physical design, or modifying policies. And so when we think about these strategies, we're able to identify that local condition. For every local condition, we map a comprehensive set of strategies. And as we work through implementing all of those strategies, we achieve change within that local condition. which, Brandy, back to your conversation about instant gratification, gives us that short-term change that we're seeking. And so if we take this local condition, for example, youth share prescribed opioids with teammates to enhance athletic performance post-injury, if we compare this to our speeding example, when we looked at providing information strategies on that picture, we saw this speed limit sign. But if we're thinking about our local condition of youth sharing prescribed opioids with teammates to enhance athletic performance post-injury, we might have signs in the locker room, or media campaigns on television, or coach or team meetings about the dangers of opioid misuse. Building skills and strategies in our speeding example, if you get a certain number of speeding tickets, and I'm not saying I know this from experience, but I do know that if you get too many speeding tickets, you are invited to participate in driving school. Well, if you take our opioid local condition, we could provide trainings for student athletes, for their parents, for coaches on non-opioid alternative pain treatments, or offer continuing medical education credits for prescribers, or training for student athletes and their parents and coaches on the dangers of opioid misuse. Again, we want to be comprehensive here. Enhancing support on the dashboard of the vehicle. In the picture you saw a speedometer. For our local condition of youth sharing prescribed opioids with their teammates, we could have physical therapists joining the teams at practice and having athletic trainers monitoring student athletes if they're not in the shape to be practicing. By changing access, we had a governor. You all circled a governor on the dashboard of the vehicle. I happen to have a governor on my vehicle, which keeps me out of trouble or keeps me from giving my quarterly donation to the city of Knoxville. With our local condition of opioids, we can offer appropriate physical therapy to students who are they're doing physical therapy during practice when they're injured, so that they don't feel completely left out. Changing consequences, if we're speeding, that speeding ticket, that police car sitting there, we know that there's a chance that they will catch us for going over the speed limit and give us a ticket. With opioids, we could offer non-punitive mandated treatment options for students who have opioids at school or athletic events. Physical design strategies, we saw the speed bumps. Local condition with opioids, parents could keep their children's medicine locked at home and only dole out the amount of medication they need at any particular time. By modifying policy strategies, we could, in our picture, we saw that if drivers were speeding on that road, they might have to go to court, or we have policies that stipulate how fast or slow you have to go on a specific road. With respect to youth sharing prescribed opioids, we can collaborate with an athletic department to adopt non-opioid policies. The important take-home message here is that our strategies work together, and they are both comprehensive and complementary with one another so that we maximize our reach for the entire population. Because just like no single strategy is likely to prevent you from speeding, the combination of all of those strategies is probably going to at least slow you down some of the time. And if we incorporate all of those ideas across the entire community, then we're likely to hit the majority of the people. Same strategies apply for all of the work that we do. And so this is just an example of youth, of a comprehensive approach. These are the same ideas that we've just talked about, but we want to make sure that we are including activities within each of the 7 strategies for community level change. And so I'm going to turn things over now to Carlton to walk us through how coalitions are creating partnerships in communities across our country. So Carlton?
Absolutely. Oh, well, I just want to take a moment and just make sure that was a lot of that was a lot of information that Stephanie just shared. Just a couple of quick ideas or quick thoughts or questions. For those of you who are willing to come on camera, please do so. But now is an opportunity to kind of engage with a little bit of conversation around what you've heard, and so feel free to do so. Thoughts, questions that you all have right now based upon the information that was just provided. And I'm from the old school now. I'll wait for a volunteer and then we'll shift from volunteering to voluntelling.
This is Crystal from Delaware.
Hey, Crystal.
Hi. One of the things that she actually stated, not only have I been in prevention for years, but I've been in the nonprofit scene, and with Delaware being a little small state,
Right.
I love the fact that New Jersey, and in fact, it was kind of led by the DIAA, which is the school after the sports, along with Bon Jovi, who everybody knows, after his daughter went through the battle of addiction. And he actually has put up money that every student that wants to play sports has to be drug tested. And I freaking love that idea. I mean, I think it should be mandatory in all 50 plus 51 states if that passes, but whatever, in all of our states, because how can we lead by example and say, okay, coaches, you have to get good grades, you got to be this, you got to do that. And then the other issue is, I feel with that, because I feel really deeply with this, is my son is a senior, 18 years old, academic, 8 concussions, 4 breaks, multiple times. And the first thing I say when I walk in is, we're not going to have any opioids. I have 3 brothers that are addicts. My father was an addict, and we are not going to have opioids. Do you know, I literally have had opioids pushed down our throats to the point that they, at one of the hospitals, asked if I needed to see a psychiatrist because his break was so bad. And I said, no, evidently you don't understand addiction. So I just wish that we would be able to jump on that bandwagon. And I've said it year after year, if New Jersey does it, then usually Pennsylvania does it, and then Delaware slowly comes in after Maryland catches on with it. But it would just be a major control for youth right there. I mean, and when I talk to the school districts, you know, most of the at-risk youth, they try to keep them engaged into support in sports, because we also know that it helps with the graduation rate. So if we're keeping kids in school and we're keeping them healthy, then drug testing to play a sport seems to be the next step. And I'm going to get off my horse.
I think you raise a very interesting point, and I think what we have to really consider at this juncture is community readiness, because each community is at a different stage of readiness. And if we take readiness where people are, sometimes we have to prepare the soil a bit before we jump into some of these higher order strategies. And in my experience, I was summoned to the White House a few years ago to the West Wing to have this conversation with the president and the cabinet. And this was the basis, the foundation of our conversation was, we have to meet people where they are. We can't just automatically pick these high order strategies that we know as prevention professionals are effective.
Right.
But we have to meet people where they are with respect to readiness and work through the strategies to achieve readiness in the community that is accepting of these different practices. In my career, it took us in Anderson County, Tennessee, about 7.5 years to get to the point where physicians would prescribe first a non-opioid treatment alternative in lieu of an opioid. And sometimes we have to speak their language, because
right.
And in fact, the very first time I ever presented in Delaware was with Carlton, and I presented on benefit cost analysis of substance use prevention. And it was through that project that I learned that not everybody cares about the number of people who die from a drug-related overdose. Sometimes the thing that's most important to them is money or taxpayer funding. And so sometimes, especially for the insurance companies, we have to shift the conversation to what is the most effective, financially cost-effective treatment option, and how can we show that treatment using non-opioids is more cost-effective than using opioids. So really gauging that community readiness and using the conversation that ties to what the community cares about is where we're going to be successful in our efforts.
Right. And honestly, I was hoping that it would be a fix when we were able to get the wellness centers into our schools. And when we started giving education about, the first thing that they do when they come to sports is they have a hour-long concussion education training. Well, if we're setting these kids down the first day of practice every season and we're saying, here's about concussions, then let's educate them about opioids and addiction too. So I am 100%, and I would back any way, but I would love to figure out a way to get that done in Delaware. So That's
Thank
it. Thanks, everybody.
Thank you, Crystal.
Well, being
Go
part
ahead,
of
Dana.
one of the largest youth organizations in Delaware, this is a start to a real growing amount of work that could be done here. Being someone that is heavily motivated and determined to push this prevention work, I'm working closely with our executive leadership team on finding a place to start and a readiness as an organization with all of the communities we serve across the state. So, and finding the communities in which, you know, are ready for this work with us, and working with all different organizations as well. So we're looking to really start to partner and start to build capacity on this work, and looking at a coalition building in the Dover area downstate. So readiness is, I think, exactly where we're working toward currently to really start building. So that speaks with me right now, because looking at the SPF framework and the fact that we have 55 plus sites and we serve kids who need us most, families who need us most, we have the greatest opportunity to start to dive real deep in this work. But where we start and readiness is the key. So that's a big piece and kind of where we're at. And so I'm learning and finding a space on where we really start to develop the work that we're setting the groundwork and the framework for this year.
Right. Yeah, and
it's a lot. It's a lot of info.
Yeah,
it is, and I had done a little bit of work on my own because my son graduates, and then I get to be an empty nester, and I had ran CACFPs and FFP programs for the state of Delaware for years and know the bidding process, and that's where I said, if you're allowing these contracts to come in from these vendors like Premier Orthopedics or different doctors that come in and they're the vetted orthopedic doctors that are out there and they're the ones that our kids are seeing, that they should automatically have a prevention, opioid-free prevention contract signed if they're going to have these bids. And that should be in the RFPs that they go after anyway. So of course, this needs to be done through DOE, Department of Education, to begin with any biddings that come down. So it should be a contract level and especially state level. And then, but that was my way of thinking too, because then when all the wellness clinics come in, then I'm like, okay, well then you have Bay Health who's running most of those or whatever hospitals, and they should sign an RFP saying, yes, we're not going to prescribe opioids. Boom, we're going to do drug testing. Boom. And then there you have it. You have the two major providers of our youth right there. So that's, I'm off my soapbox.
Okay, keep the soapbox on standby, all right? Because we're going to have an opportunity to really engage in a much robust conversation. I want to thank both Crystal and Danielle for bringing those thoughts and those ideas and that energy to the conversation. Stephanie, thank you so much. That was a good bit of information, all relevant, all purposeful, all intentional to set us up for a wonderful conversation that Angie will take us through. Folks, here's what we're going to do. We're going to take a 5-minute break, not right this second. Hold on. A 5-minute break, just setting you up. Angie, if you wouldn't mind, just set us up for what to expect after we come back from the break, and then we will see everybody back here. Do not shut down your computers. Don't log out. Just go to black and go on mute, but come back at 3:05 on the dot, and we'll be started. But Angie, what will we be doing when we come back from the break?
Crystal, we'll be walking right where you want to go.
I know.
We need to explore these.
Running.
Okay, we need to be exploring these edges and what are we learning from one another and how can we really build on it, and what are some of those things that we just need to forget about and move on to some better things. And so there's some great ideas that are getting generated. We're going to keep on rolling with those. And so this is your time that we're going to really think outside the box. So go grab a coffee, a soda, whatever you do in your part of the neck of the woods, and be back in
5 minutes.
5 minutes.
Dave, can you put us in a breakout?